Dear Chairman, thank you very much for the invitation to the EBC Congress 2021. And I am sincerely concerned for defending my presentation on the issue two stent left main procedures are unsuitable for attenuated double antiplatelet therapy regimens and that should be continued lifelong. That is my point. Concerned why? Because we are witnessing a historical context where there is a mushrooming of publications on all the drawbacks on double antiplatelet therapy after PCI, mostly in patients with high bleeding risk. And this is strongly supported by the recent publication of the sub-analysis of the Twilight Complex investigator led by George Dangas, where you can see that there is no reduction in ischemic events at the cost of a significant decrease in bleeding events when Ticagrelor is maintained after withdrawal of aspirin early after complex PCI. Such findings have been recently replicated by the sub-analysis of the Smart Choice trial, always among complex patients where bifurcation is a big part, and results are similar. On the other side, I have to face the public prosecutor who has written a landmark manuscripts on physiology and pathological distribution of the plaque in left main coronary artery disease, as well as elegantly depicted the difficult balancing between the technical complexity of approaching left main and the extension of the territory at jeopardy when approaching the left side branch. In this manuscript, you can find also the technical peculiarities of this approach that have not to be disregarded, as the careful planning is strictly correlated to long-term outcome, as here you can see in a couple of recent publications that double stenting, when not planned, bears an increase of 1.8 hazard ratio in hard endpoints events. And this risk can be attenuated by careful imaging that allows adequate stenting positioning, vessel wall deployment, symmetry of the struts, and in some cases, as in this one, when monitoring, it can also depict uncovered parts of this relevant part, as here you can see the ostium of the left circumflex not covered by a T-stenting procedure. Therefore, there are no currently available manuscripts focusing on that duration, but they are mostly derived from large trials in which there are sub-analyses available on complex patients. The only one is this one published from a subgroup of the Grandes trial, where DAPT interruption does not have any drawback in patients with single stenting, but has an increase, a threefold increase of hard endpoints when the procedure is not supported by careful imaging. Therefore, we wrote together with my public prosecutor a white paper on the antithrombotic therapy after percutaneous coronary intervention in bifurcating lesions, where there are 4 issues that we focus in: clinical presentation, bleeding risk of the patient, stenting strategy, and intravascular imaging. These have been the main image, the central image. We can disregard the single stenting strategy. We can focus only in double stenting and bailout stenting. And we suggested a prolonged duration on the antiplatelet therapy after such procedures. Now, when patients have high risk and when there is imaging, careful imaging, we reduce this suggested duration. And after the publication of the Twilight complex as the smart choice, I'm also willing to negotiate this point, shortening further to 3 months in very selected cases when the patient is at high bleeding risk and IVUS has been performed to optimize the strategy, and to reduce to 6 months when the patient is at low risk and the IVUS has been performed. But I'm not available, I'm sorry, to go further than this point. Thank you very much for your attention.